Okay, so I'm going to talk about the stuff that referring physicians need to know about transplant. So it's going to go a little bit beyond just the indications, contraindications for transplant, but things that you may be counseling your patients on in regards to transplant. So there we go. So we're going to look at referral criteria as it relates to the specific diseases that we transplant for. We'll talk about the relative and the absolute contraindications for transplant. And then, again, the stuff that you guys should know if you ever talk to patients about transplant, when you talk to patients about transplant, things that they may ask you about. So, now, my disclosures, I don't have any conflicts of interest, and all the pictures I just downloaded off of Google Image, so if they're copyrighted, they're on Google Image. So here's the spiel. So this is an abbreviated version of the talk that I give to all patients that I see for their initial consult for transplant. Dr. Jalil knows this speech. You should know this speech. Dr. Eng maybe remembers that speech. Juan should know that speech. So actually, here, Juan? No? All right. So otherwise termed as the good, the bad, and the ugly of lung transplant. So the first thing I tell patients about transplant is what it's not. Transplant is not a quick fix. So a quick fix is a hip replacement. Now I say that a hip replacement is a quick fix because what do you go through when you have a hip replacement? You schedule the surgery, you have the operation, you do 8 to 12 weeks of physical therapy, then you're good to go for the next 20 years. You don't have to think about it. Lung transplant is nothing like that. Lung transplant is not a quick fix. Lung transplant is more like a swap shop. You're trading one disease for another. Lung transplant, you're exchanging one set of problems with your original disease. You exchange those for a different set of problems once you get the transplant. And I say it's trading one disease for another because if you think about any kind of chronic, severe disease that you may have, someone with bad diabetes, someone with bad multiple sclerosis, bad congestive heart failure, you think about what they go through. You go to the doctor frequently, you take a whole bunch of medicines, get a lot of blood work drawn, you have a lot of procedures done, a lot of radiology, a lot of diagnostic testing, and you have problems that wind you up in the hospital. That's with any kind of chronic disease, no? A lot of our patients with CF, COPD, interstitial lung disease, they go through all of this. But that's exactly what it's like to live with a lung transplant. Because when you have a lung transplant, there's still a whole lot of doctor visits. You take a whole bunch of medicines. We do a lot of blood work, a lot of bronchoscopies, a lot of pulmonary function tests, a lot of CAT scans, x-rays. And the reality is people get admitted with problems related to their transplant. So that's why it's trading one disease for another. The reality is everyone who gets a lung transplant is going to have some sort of problem. Guaranteed 100%. No one goes through transplant without anyone having some kind of problem. Now the problems we see are variable in severity, things that are mild, things may be self-limited and go away on their own. Other problems may be severe, life-threatening. Things like the development of rejection, things like malignancies, adverse drug effects. So from mild nausea, diarrhea, tremor, hair loss, personality change, mood disorders, to things like developing diabetes, high blood pressure, high cholesterol, risks for cardiovascular events, strokes, heart attacks, development of renal failure, where 1 to 3% of our patients may need long-term dialysis. So, again, no one goes through transplant unscathed. The biggest downside to transplant is that a lung transplant doesn't last forever. Now, on the average, transplant lasts about 5 years. So this is data from the International Society of Heart and Lung Transplant, looking at the registry, and it spans from 1990 to 2015. And what you can see in this Kaplan-Meier plot survival over time, we can see that single lung transplants, on the average, last about 4.5 years. Double lung transplant, lasts about 7.5 years. So averaged out together, all comers, roughly about 5 years on the average. The misconception is that once you get a transplant, you're doing well for 5 years, then the wheels fall off, the lungs disintegrate, and poof, you're done. That's the misconception. What we mean by that 5 years is the average, it means half do better than 5 years, half do worse than 5 years. The other way I put it to patients is that for every patient that lives 10 years, 15 years with a transplant, that means someone doesn't make it 1 year with their transplant. And when you average it out together, it comes out to about 5 years. So there are no guarantees if you're going to be the 10-year person or the 1-year person. You don't know. Somewhere around there, it's just going to be 5 years on the average. Now, the benefits to transplant are twofold. The first main benefit to transplant is prolonging life with a transplant. Now, we said on the average, a transplant lasts about 5 years. By the time we are actually doing a transplant, we anticipate that the patient probably has about a year left without the transplant on the average. So that when we do the transplant, if they can go on the average 5 years with the transplant and otherwise have only a year left without the transplant, we kind of figure we may be extending the life by perhaps 3 or 4 years, again, on the average. Could be much shorter, could be much longer. On the average, we think we're extending someone's life. The other benefit to transplant is improving quality of life. So what I tell patients when they get transplanted, our expectation after transplant is that they can do anything, everything they want to do without shortness of breath, without any oxygen. So if you think about the patients that we're transplanting, most of them can barely walk 800, 900 feet. They're strapped to their oxygen, dragging along E-tanks, 6, 7, 8, 9, 10 liters. So this is what we expect, that they can do anything, everything they want without oxygen, without shortness of breath. Now, that is our goal of transplant. Not everybody reaches that goal, but it certainly is a realistic goal, and it's certainly an achievable goal, and that the majority of patients, even if they don't reach that goal, are still better off having had the transplant than not. Questions to this point? Sound familiar, Jill? I hope so. Okay. All right, so these are a lot of questions that I get. These may be questions that you get if you ever bring up transplant. So the first question is, how long is the waiting list, or how long do you have to wait for a transplant? And pretty much the answer is it doesn't matter. It's sort of irrelevant how long the list is, because there are a number of different factors that determine how long someone waits for a transplant. We've had someone on the list for as short as 8 hours. We've had someone on the list as long as 4 years and still going. So there are a number of different things that causes someone to wait longer than others. And we'll go over a couple of those. So that begs the question then of how are lungs allocated in the United States. So previous to 2005, lungs were allocated kind of like you were at Taco Bell. You formed a line. Once you got to the front of the line, you were served your chimichanga. That is no longer the case. So in 2005, we changed how lungs are allocated in the system. Now we base organ priority on a score. So every patient who wants to get a lung transplant will have a score, and that score is determined based on actual data. And the way that score is determined is based on some gigantic computer algorithm looking at using a Cox proportional hazards model, balancing the risk of death on the wait list versus survival after transplant. So we want to be able to balance those things. So we want to be able to offer the organs to people who are going to do the best with a transplant. And so it takes into account these data that we determine on the pre-transplant side. We put all that data into a national database, and it spits out a score for us. It gives us a score from 0 to 100, 100 being the highest score, and that if you were 100, you would have top priority for lungs. So what's implicit in this is that these are always changing. So someone's score on the list is a dynamic thing. So someone's position on the list is constantly changing. So you get sicker, we update the data, you move up the list. Someone is sicker, gets ahead of you, you move down the list. You get better for whatever reason, when we update your data, you move down the list. And so we are required to update this every 6 months so that the scores are reflecting what the patient is actually doing. The other thing that determines someone's weight on the wait list is size. So obviously we have to match size for organs. So you can see Lucy Liu here and Josh Hartnett. So that if, for example, Josh Hartnett were the donor, you take a very tall white man, there's no way you're going to stuff those lungs into a tiny Asian woman. You're going to need a pretty big shoehorn to get those lungs in. On the other hand, if you take Lucy Liu's lungs and try to put them into Josh Hartnett, they're going to be rattling around in there like a game of Yahtzee. So it's got to fit. So size match is particularly critical when you're talking about wait times for people who are on the extremes of size. So if you are a recipient, like our transplant, for example, if our lung transplant surgeon were a candidate for transplant, him being 6'6", it would be very difficult for him to find organs. Likewise, we have a patient who was 4'10". She's been on the waiting list for 2 years. She's got a decent score, but it's hard to find 4'10" donors unless you're a kid, and those lungs typically go to kids. So if you're in the middle, it's probably not going to be an issue, but it does affect how long someone waits on the wait list. So a lot of patients, they think they're doing very well. They think that they just have bad lungs, that if they got their lungs, they would be great. A lot of times we turn those patients down for different reasons. They think they're in otherwise good health, but like I said, they're not candidates. So a couple of the reasons why they may not be good candidates for transplant is, number one, nicotine. So patients who are actively smoking, makes sense that ethically you shouldn't be putting lungs into someone who's still smoking. But more than just smoking, most programs will have complete abstinence from any kind of nicotine products. So e-cigarettes, tobacco, chew, patches, gums, whatever. We do random drug testing just the same way athletes are tested for performance-enhancing drugs. So we call up a patient on the list and we tell them you've got 24 hours to go pee in a cup. Any kind of nicotine on there, we're a little cynical. We think you're smoking. We take you off the list. You don't pee for us in 24 hours. We think you're using and don't want to admit it. We take you off the list. We consider that a positive. So nicotine use, drug abuse is also a big thing here. I'll leave it at that. The other problem that's not so unique to Kentucky, but kind of is obesity. So most programs, I will say all programs, have a weight limit. Now that can vary, and we'll talk about that in a little bit. For us, we're a little more generous. Generous, get it? With our weight limit. So we will take patients who have BMIs up to 34, which is they can be quite sizable. So, like I said, limit, you have to be below that, just because of risks of morbidity from obesity and having surgery. Patients need adequate social support, so you can't do transplant alone. Just like someone undergoing chemotherapy, they can't do it alone. They need support people to help them at home, bringing them to appointments, to provide psychological support. So patients who are living alone, they got the neighbor next door who they don't really know, they just say hi to, not good enough. We need someone who can fix their meals if they need to, someone who can put out their pills if they need to, someone who might even need to wipe their butt if they need to. That's the kind of level of support that we need. And finally, probably the real big thing that's hard to grasp is non-adherence. So patients who have demonstrated non-compliance with therapies, appointments, etc., they really need to prove to us that they're going to take care of these lungs the way we tell them to. Because ultimately we have to do right by the donor as well too. So if they're not going to take care of the lungs, if they're not going to do what we say, then we'd rather put them in someone who will honor that donor. So what do I need to do until I get a transplant? So these are the things that the referring pulmonologist, as well as their primary care doctors, need to be doing when patients are on the list, patients are considered for transplant, patients are being worked up for transplant. Number one is pulmonary rehab. That's probably the most important thing, at least for our program. That's probably the best thing anyone can do for themselves is pulmonary rehab. Bottom line is the patients that are more fit, who can walk further, they do better with their transplant. Patients who are debilitated, can't move, stuck in a chair, don't do well with transplant. So they need to be enrolled in pulmonary rehab. Keep up with your vaccinations. Flu shots every year, make sure they get their Prevnar, their Pneumovax, their Tdaps, etc. And most importantly is just routine health maintenance. Keep your diabetes under control, keep your blood pressure under control, all your routine cancer screenings, be in the best possible health going into transplant. Questions?
How do you take someone off the transplant?
Those things. Sorry? Besides those things, we can go through some of the other. We'll go through some of the other contraindications. I don't know. You could be abusive to the staff, things like that. I don't know.
People try to game the system by trying to be more sick. It sounds like being more sick is much more higher than
Yeah, and there is a too sick as well too. So, so we have a minimum criteria as well. So, as I said, patients need to have a certain level of fitness to do well with their transplant. And in particular, we use a 6-minute walk. And that we have also a minimum that they need to achieve for listing for transplant. So if you kind of do it half-assed, trying to get a better score, we may take off the list and have you do 2 more weeks or 2 more months of phase 2 pulmonary rehab. But yeah, we're not that naive to think that, oh no, they're giving it, yeah. So.
Yeah, I was curious about the psychological workup for pre-screening for a lot of these patients. I feel not just in lung transplant, but other transplants. A lot of times they end up in the hospital and they have major psych issues. And so I was wondering.
Yeah, it's hard to predict those things. You have people who just totally decompensate after the stress of surgery, especially if things don't go well the way they plan. Just that stress in and of itself causes people to decompensate. A lot of these medicines have psychotropic effects as well too. The immunosuppressants, the antivirals that we use cause delirium, personality change, psychosis, delusions. Put that together with ICU delirium, flipped sleep-wake cycles. They go bonkers. They're nuts.
Can you update their score more than everything?
Mm-hmm.
If they get sick,
Yes.
you would update it.
I can update as many times as I want, even in a single day. If I just get new information, I'll plug it in.
our program, especially for transplant candidates. Do you prefer to know that these patients are admitted or have everyone else proceed?
Usually I know they're getting admitted. But yes, if it slips through, I need to know, because just for that fact, if they're sick and we need to update them to get them a better chance of getting transplanted sooner, then we need to know about that. All right, indications, contraindications. So, most important thing to know about not so much the indications, but but the contraindications, it's a moving target. So contraindications may kind of change over time, and we'll talk about that. So what you need to know is who controls the moving target. What controls that moving target? I'll tell you, it's got two thumbs. This guy controls the moving target. So that's why wherever you end up, you need, if you're going to be in a specialty where you're going to be referring patients for transplant, you need to be able to contact your transplant center. You need to be able to contact the pulmonologist and know what they're doing. Because every center is different. Every center's got their own target, and you have to know what that is. And it can change as well, too. For example, things that we weren't doing 7 years ago when I came here, we are doing now. So we're transplanting patients with chronic active hepatitis C. We're transplanting patients off of ECMO. We're transplanting 75-year-olds. So it's changing, and it depends on my mood that day, whether we're going to take that patient or not. So it behooves you to call me. I get lonely, so give me a call. So in terms of the contraindications, indications, I encourage you to, for the purposes of your boards, read this document. This is the most recent update by the International Society for Heart-Lung Transplant, talking about the specific criteria, the numbers. I figure that that's kind of dry and boring to read off a slide. So you can read that for your test purposes. And the stuff that I'm going to go over is more gestalt on what you do in real life rather than what you answer on a test, and sort of where these data come from on why you should refer and when. So if you actually want the numbers of what FEV1, what DLCO, how many meters can they walk, this is the document to go to. So the general indications for transplant, they need to have end-stage progressive lung disease. So progressive, meaning that it's not going to get better. And in fact, that we predict that they're going to die within 2 years. Now, this may be difficult to determine sometimes if it's going to be progressive and if it's going to be fatal. Like we talked about that one case, you were in the ICU, that big guy with the hypersensitivity pneumonitis. If that guy didn't have a BMI of 40, I would have transplanted him. But Dr. Rivas cured him, and he's probably home getting re-exposed to whatever. So we may see him again yet, but nevertheless, I mean, that's why we brought him to the hospital, was to see if we can transplant him. They also need severe exertional limitation. So we don't want, even if someone's got really bad lung disease by PFTs, if they're still hopping and bopping around, then we want to reserve that for when they do decompensate. And they also need optimal medical therapy that they failed, if there is anything available. So, disease-specific guidelines. So for the diseases that we transplant. So first, for cystic fibrosis. So these, when you see these images, CAT scans, these are actual patients that I've taken care of and used their images. So this is obviously pre-transplant, post-transplant for CF. So this is where the data come from. And this is an old study from 1992 looking at a cohort of CF patients from Toronto Sick Children's Hospital. So this is a seminal paper looking at predictors of mortality in patients with cystic fibrosis. So as we said, we are looking for a 2-year 50% mortality. So in this, here's 2 years in the black bar. So let's look at 50% mortality. So anything below that is probably when we should look at referring these patients for transplant. So FEV1 at 2 years, so somewhere between 20 to 30% is probably the time to start referring those patients for transplant. So according to those guidelines, roughly 30%. Below 30% is when a patient with cystic fibrosis should come and see us in transplant. PO2, so basically once they develop hypoxemia, PO2 less than 60. Similarly, once they start developing hypercapnia with their PCO2 over 50. Again, in CF, those are bad prognostic indicators that they should see us. So FEV1 less than 30%, presence of hypoxia, presence of hypoxemia. Now, in patients who have relatively higher FEV1s, don't have the same degree of hypercapnia, don't have the same degree of hypoxemia, they still may be appropriate for a transplant evaluation if they have, in particular, an accelerated course. So CF patients who are having frequent exacerbations. So frequent exacerbations and accelerating disease as determined by someone with, where's my pointer? Recurrent pneumothoraces. So some of these things we can't put into a calculator, but we know that patients who have the recurrent pneumothoraces overall don't do as well. So these are people that, again, we might consider evaluating for transplant. Other sign of accelerating disease, in particular a young woman, is cachexia. So these are patients that, despite nutritional supplementation, they have pulmonary cachexia, continuing to lose weight with their frequent exacerbations in cystic fibrosis. And finally, patients with hemoptysis. That's also despite bronchial artery embolization. That's for you.
That's not.
So pneumothoraces, malnutrition, and hemoptysis are also pretty bad signs in patients with cystic fibrosis. Now, patients with emphysema, this is a right single lung transplant. You can see the difference there on CT scan. So again, this is really old data from 1986, and this is the data that was used to generate the first guidelines for referral for transplant. Again, we're looking at 5 years, 50% mortality. So unfortunately, on these data, we have 60% survival at 3 years when your FEV1 is less than 30%. So when the guidelines came out, the recommendation was for an FEV1 of less than 25%, and that's still probably reasonable level to target for COPD, recognizing that's still probably a ways off before they actually might die, even with an FEV1 of 20%. So this is data from the original BODE index paper from Barcelli. And this has been subsequently incorporated into the updates in the guidelines. So if you break down the BODE index by quartiles, so BODE index score of 0 to 2, 3 to 4, 5 to 6, 7 to 10, we can see that patients with the highest BODE score have, let's see, roughly 32, 36-month survival with a BODE index of 7 to 10. Now, the guidelines actually say we should probably be referring at 5 to 6. Realistically, that's probably pretty early. So score in the 7, 8 range is probably closer to the sweet spot than a BODE score of 5 to 6. Again, practically, it makes more sense to refer down here. Your test may say this, but that's what the data, that's what the guidelines are telling us. BODE score 5 to 6. One word about bronchial valves. So Dr. Guardiola and I were just talking about this. Having bronchial valves or bronchoscopic lung volume reduction is not a contraindication to later lung transplant. And in fact, there is a population among COPDers in whom lung volume reduction actually confers a survival benefit. So in those patients, it may make better sense to do lung volume reduction surgery, bronchoscopic lung volume reduction, as the optimal medical therapy before transplant. So patients who are not eligible for lung volume reduction surgery, or patients who may have increased mortality from lung volume reduction surgery, those are the ones that we should probably be seeing first for transplant. Anybody recall what those criteria are for patients who do worse with lung volume reduction surgery? Patients that we were killing with LVRS? So FEV1 of less than 20% and a DLCO of less than 20%. diffuse emphysema. So those are in particular, it's the PFT criteria. If they meet those two, we know that they have higher risk of mortality with LVRS. So LVRS is contraindicated in those patients. So those are the patients that you should refer for transplant. But otherwise, if they're eligible for lung volume reduction, that might be something to consider. We'll come back to that. For idiopathic pulmonary fibrosis, pop quiz. In a patient with IPF, here are 3 different courses over time, progression. So how does IPF progress? Is it linear, meaning that lung function declines steadily over time? Do you have a rapid drop and then maybe a plateau? Or do you have a big drop, a kind of plateau, another drop? What is that? All of the above. Really? Anybody disagree? Ooh, not looking too good for you. So it can do anything. So we don't have very good markers on, right, Sally? On what causes this as opposed to this, as opposed to this. We can see all of these. Now, if we have, so I made this black line here saying that this is the point where they need transplant. So once they go below this, they need transplant. The problem is predicting what time they will need the transplant. You can't predict. So you have to assume everyone's going to do this. And when are they going to do this? You don't know. So the guidelines is that if you're taking care of someone with IPF, you should have that discussion about transplant right up front. Because again, you don't know if they're going to do this or if they're just going to kind of slowly gradually decline. You just don't know. So transplant needs to be part of that discussion right up front. But you say, wait, there are medications out there that we use to treat IPF. No? So the 2 different drugs, there's still 2, right, that we use to treat IPF, nintedanib and pirfenidone. And you can see here's the drug, here's placebo, here's drug, here's placebo, just as we saw before. Decline in pulmonary function over time. Look what the drugs do. Look at that. There's better lung function with these drugs, no? But the other way to look at it, you're still going down. So what do these drugs really do to the natural history? May protract it a little bit, but if I go back a slide, they can still do this on the drug. So if you're going to start them on the drug, when do you have that conversation about transplant? Same time. So as soon as you identify someone with pulmonary fibrosis, get the idea that they may need transplant and that the drug is an adjunct to it. What about other fibrotic lung diseases? So we don't know much about prognostic indicators in pulmonary fibrosis. We have even less information in other fibrotic lung diseases like collagen vascular diseases, sarcoid, whatever fibrotic lung disease you want to pick from. And again, I don't know if they're going to get cured if we blast them with steroids. I don't know. So we make our best guess. We kind of use the same criteria and hope they do well. Pulmonary hypertension is even easier because we know even less than pulmonary fibrosis about what portends bad outcomes in pulmonary hypertension. So we know if they're New York Heart Association class 4 and they've failed parenteral therapy. So what does that mean when they fail parenteral therapy? It means that Dr. Alkhurst gives me a call and says, hey, this guy failed at parenteral therapy. Can you transplant him? So, and we don't know really what that means, how to judge that. So things like syncope, again, hemoptysis, angina may also be very bad players in pulmonary hypertension. Those are the things that we also consider for transplant in someone who's got severe, I should say, pulmonary arterial hypertension. Probably patients who have things like veno-occlusive disease and pulmonary capillary hemangiomatosis have perhaps worse outcomes than idiopathic or the class 1 pulmonary arterial hypertension, so they should probably be referred even sooner. So, generalizations. So this is probably the most important slide that you need to take away from this lecture when you're going to refer someone. So, any lung disease, if there's cor pulmonale, that's bad. We need to be seeing them. Again, pulmonary hypertension, a little different. But if you've got COPD and cor pulmonale, idiopathic pulmonary fibrosis, cor pulmonale, any interstitial lung disease with cor pulmonale, cystic fibrosis, cor pulmonale, that's bad. Patients, again, hypercapnia, that's bad too. Any disease, hypercapnia, need to be referred. Hopefully in some of these diseases you would have referred them before they've gotten to this point, but that doesn't always work out that way. So sometimes you may be seeing them when they already have cor pulmonale, when they already have hypercapnia. You see that they should be referred promptly. COPD, as we talked about, you really can't refer too late for COPD. These patients just kind of linger on forever. As bad as their lung function is, they can kind of hang around there for a long time. So if you sit on the COPDers, they'll still be there. In contrast to the pulmonary fibrosis, which we already talked about, they need to be referred up front. And like I said, you need to have a good relationship with your transplant team to be able to, refer someone who's got 100% vital capacity on no oxygen, walking 1,600 feet with pulmonary fibrosis, knowing that they may need a transplant 3 months from now. I think that's all on that one. So absolute contraindications. There are probably fewer absolute contraindications than relative contraindications. And some of the absolutes are kind of also relative as well too. So patients with severe debility, patients who don't have any rehab potential. As we talked about, patients that go into transplant with a better level of fitness do better than those who have a worse level of fitness. Active cancer. So if they've got an active lung cancer, colon cancer, breast cancer, kidney, whatever, other than non-melanoma skin cancer, absolute contraindication. Now we can talk about when they can be referred after they're quote-unquote cured or in remission from their cancer, but active cancer, no. Patients with other severe end organ dysfunction, like patients who are on dialysis, patients with pulmonary portal hypertension with cirrhosis, congestive heart failure. For lung transplants alone, having any kind of organ dysfunction is a no. Again, we can talk about what organ dysfunction means. Patients who are hemodynamically unstable, acutely ill, critically ill, they don't do well having a big operation. And patients with uncontrolled chronic infections, so things like tuberculosis or other non-tuberculous mycobacteria, any kind of chronic infection that you can't control is a contraindication, absolute contraindication to transplant. Now, there are more relative contraindications. Now, age is one. When I started, we had a firm cutoff of 65 years old, and that obviously didn't quite make sense, because if you're 66 years old, should you now be not eligible for a transplant, all else being equal? Probably not. But again, where to draw that upper limit is a difficult one. Like I mentioned, we transplanted a 75-year-old like 6 months ago. Probably wouldn't do that again, but where to draw that is a difficult one. Weight, we talked about. Again, where to draw that upper limit on weight is variable. Some programs will not transplant patients with a BMI over 30. We'll go as high as 34. Likewise, there's also a lower limit, and that varies from program to program as well too. So for us, a BMI of less than 17, we'll need to put a tube in and give them tube feeds to get their BMI up. Other centers won't transplant anyone with a BMI of less than 18, 18.5. So again, you need to talk with your transplant team. Chest surgery, pleurodesis, not an absolute contraindication. I don't know that I even put it under a relative contraindication. It just makes your surgeon really grumpy if they're trying to chisel out a lung at 2 o'clock in the morning. So it does make it a bloody mess. But we've done it before, so it's not a contraindication. If you can do things to avoid pleurodesis, it would be better. But again, a call to your transplant center, see what they do, if they would take it or not, or if they have any other options, might be prudent. Infections with highly resistant organisms like Burkholderia species in patients with cystic fibrosis, non-tuberculous mycobacteria, in particular rapid growers like abscessus. So I don't want to transplant those patients here. I'll send them to Duke. I'll send them to Pittsburgh. So for us, that we just won't do that. We talked about hepatitis B. We're considering patients who are chronic active hepatitis C. So one of our fellows last year presented a paper where we transplanted 2 patients with active hepatitis C and cured them from their hepatitis C a year later after their transplant. And we had another patient in that abstract in whom we chronically suppressed their hepatitis B and then subsequently transplanted them, and they did okay. Coronary artery disease is a difficult one. Some programs, for example, Vanderbilt turned down a guy because he needed a stent. We took him and transplanted him 6 months later, and he's doing fine. So depending on how much coronary artery disease, it can be a discussion there. And then the role of a multi-organ transplant. Some centers will do them, some centers won't. So we talked about significant organ dysfunction as being an absolute contraindication. But if you can get over it with a multi-organ transplant, maybe. So again, depends on your center. Bridge to transplant. Again, these are things that I'd mentioned that we weren't doing years ago that we're doing now. So transplanting patients off of ECMO. You can see he's not intubated. I don't see a trick. So we've done this a couple of times where they're awake, have the cannulas in place, they're still exercising, but waiting on a transplant list while they're on ECMO. And patients who are intubated with an oral endotracheal tube, we will transplant those patients too. Now, for us, we need to have them already worked up for transplant on the list. They decompensate into one of these. We'll still transplant them as long as they don't have other organ dysfunction and keep them on the list. Whereas if you're a referring doctor and then you intubate them and then they need ECMO and I've never seen them before, probably going to say no. And that's just me and my choice. Was that it? Do we have time? Quick case. Some of you recently took care of this guy, just to highlight the issues about referral, timing of referral. So this is a 56-year-old man. He was previously healthy, 20-pack year smoking history. He quit 12 years ago. So in January of this year, he developed a cough and was treated for bronchitis. 3 months later, he had no improvement, and now he's developed dyspnea on exertion. So his primary care doctor ordered an echocardiogram and saw some RV dilatation. So he treated him with bronchodilators. He still had no improvement with the bronchodilators, and a couple months later was then referred to ENT, and also simultaneously referred to cardiology. He had a nuclear medicine stress test, which did not demonstrate any ischemia. The cardiologist did order a ventilation perfusion scan, which was grossly abnormal. So that patient then, in August, was referred to a pulmonologist. The pulmonologist promptly obtained a CT scan and saw pulmonary fibrosis. Within 2 weeks of seeing the pulmonologist, that CT was done. Patient was started on 3 liters of oxygen, referred to transplant, and started on OFAV. So I saw the patient in transplant clinic 3 weeks after he saw the pulmonologist. and I scheduled a transplant evaluation to assess him for candidacy for transplant 3 weeks later. However, like 5 days before he was supposed to get evaluated for transplant, he had a severe IPF exacerbation. He was admitted to his hospital locally, and he was put on high-flow oxygen at 50 liters a minute with BiPAP at night. We transferred him to our hospital for urgent transplant evaluation. So he was not able to do a 6-minute walk. He would just sit up, desaturate into the 70s. It would take him about 10 minutes to get back up over 90. We did his left heart cath. He had 80% left main disease. So we deemed him not a candidate, and he was placed in hospice. And 3 days later, he died. So things to point out here is that perhaps some of these things aren't necessarily absolute contraindications to transplant. This guy was really fit, and he declined so quickly that he was still a pretty robust guy, that we were okay with sort of overlooking our fitness criteria because we think he had very good rehab potential. He did have left main disease, so we talked about him maybe doing a bypass at the same time of his transplant. We decided ultimately against it because of how bad his heart was, needing cardioplegia for a CABG plus a transplant. This was going to be very high risk. So in that case, we decided not to transplant him. Now, if maybe we had another month with this guy, we could have stented his left main, let him get over the time required for the dual antiplatelet therapy, and then come back in and then do a transplant, and then do a CABG. We just didn't have time. So part of why I bring this case up is, too, to underscore that patients can go from well to dead in 8 months with IPF. Now, the pulmonologist did everything right. I mean, he got him to me as quick as he could. And not saying that the primary care doctor didn't do that bad either, considering it usually takes a couple of years before they make a diagnosis or get him to the right place. But this just underscores how quickly someone can decompensate with IPF. I think I will end there. That's it. Questions?